Hello, my name is Dr. Amanda Barrick, and these are my colleagues, Dr. David Sang, Dr. Susie Cook and Dr. Sally Sang, and we're all consultant anaesthetists at the Northern Hospital in Melbourne, Australia. In this video, we'll cover safe airway management and oxygenation using the Vortex approach.
By the end of this video, participants should have a basic understanding of the following topics with regards to safe airway management. Firstly, to define safe airway management and oxygenation. Second, to understand the required equipment and staff for safe airway management. Third, to understand the Vortex approach, which includes how mask ventilation, laryngeal mask insertion, endotracheal intubation, and front of neck rescue fit into this approach. And finally, the importance of documentation and communication about the difficult airway.
All patients undergoing general anaesthesia will require the use of techniques and equipment to maintain airway patency and ensure adequate ventilation and oxygenation. In situations where intubation is planned but is difficult, the anaesthetist needs to move to alternate techniques to ensure the patient remains well oxygenated. Similarly, if the primary plan for airway management is laryngeal mask airway or face mask ventilation, alternate techniques need to be considered to oxygenate the patient if the best effort at the primary technique is not successful. In this video, we will discuss the Vortex approach, which is a tool that can be used during an airway emergency by the anaesthesia team. It is a shared model that enables the anaesthetist to avoid fixation on intubation and move on to safe oxygenation.
The methods for achieving alveolar ventilation in an anaesthetised patient include face mask ventilation, laryngeal mask airway, or endotracheal intubation. Any of these may be used to safely oxygenate a patient and are used during surgery and general anaesthesia. It is important to remember that an endotracheal tube is not always required for the conduct of general anaesthesia and that other techniques can be used to achieve oxygenation. Specific indications for endotracheal intubation include airway protection from aspiration of gastric content, the need for muscle relaxation and ventilation to facilitate surgical access, such as during a laparotomy, or surgery that could potentially cause soiling of the upper airway, or the need for unusual positioning and reduced access to the airway during surgery. Surgery of long duration, that is many hours, or the need for long-term ventilation, such as intensive care, are also indications for endotracheal intubation. What the anaesthetist needs to remember is that there are alternatives to achieving alveolar ventilation via the anatomical upper airway other than intubation. Some anaesthesia does not require intubation, and the plan may be to manage the airway with a face mask or laryngeal mask during surgery. Each attempt at any of these three non-surgical techniques for achieving alveolar ventilation can be optimised with the use of positioning or manipulation of the device and larynx, the use of adjuncts, ensuring the correct size and type of equipment, ensuring optimal oxygen flow, and the use of suction and consideration of paralysis to reduce muscle tone.
This list is an example of the equipment required to achieve safe oxygenation for face mask ventilation, supraglottic airway insertion, and endotracheal intubation. It covers the three lifelines in the Vortex approach to achieving safe oxygenation. It is possible to arrange this equipment in a trolley with clear labels to represent the three lifelines.
The equipment available for face mask ventilation includes different sizes and types of masks, oropharyngeal airways, nasopharyngeal airways, and methods of providing positive pressure ventilation, such as an anaesthesia circuit or a self-inflating bag. An oxygen source and suction equipment is essential for all three techniques of airway management during anaesthesia.
The equipment required for supraglottic airway insertion will include a range of types and sizes of laryngeal mask airways, and the availability of each will vary according to your location. To facilitate the best attempt at LMA insertion, aids such as a laryngoscope or introducer can assist with insertion. Adding or removing air from the cuff can improve the seal. And as with mask ventilation, suction and oxygen sources are required.
The basic equipment required for intubation includes a laryngoscope, endotracheal tube, and suction. A best attempt at intubation may require a change of laryngoscope type, moving to a different blade size or type, and the use of a stylet or a bougie to guide the endotracheal tube. It is useful to have endotracheal tubes of different sizes, in particular a smaller tube. The choice of equipment will depend on local availability, but direct and indirect laryngoscopes with different styles of blades, stylets and bougies are desirable. Staff using the equipment will need to be familiar with it and trained in its use.
During attempts to oxygenate using the face mask, supraglottic airway and intubation, the team will start to prime for can't intubate, can't oxygenate rescue. Once the decision is made, it is important to have the equipment ready for front of neck access. This would include equipment for either a needle cricothyroidotomy or a scalpel bougie technique. The needle cricothyroidotomy technique requires a 14-gauge Insight cannula, a 5mm syringe, saline, and an oxygen insufflation method. The scalpel bougie technique requires a 10 scalpel blade, a size 6 endotracheal tube, and a bougie.
Once the patient is safely oxygenated, there is time to think and make decisions about the next steps, which may include waking the patient or converting to a different airway. If an endotracheal tube is required for secondary reasons, such as protection from aspiration or ongoing ventilation in intensive care, there are advanced techniques that could be performed via a laryngeal mask. Equipment for airway exchange can include an Aintree catheter and fibre optic bronchoscope.
The Vortex approach is a decision-making approach for practitioners who manage airways. It is designed so that it can be easily followed by any member of the airway team and facilitates communication as well as decision-making. This avoids task fixation and can help the team to be primed for front of neck access should the lifelines of mask ventilation, supraglottic airway and intubation be unable to return the patient to the green zone of safe oxygenation. It features the 3 techniques used to achieve alveolar ventilation in a patient who is undergoing anaesthesia: endotracheal intubation, laryngeal mask airway, and face mask ventilation. When successful alveolar ventilation is achieved, the patient moves to the green zone at the edge, which is safe oxygenation. When we are in the green zone, the team has time to consider how to proceed. No matter which of these 3 lifelines is chosen as the primary technique, the model prompts the team to ensure a best attempt is made at each and then move on to another technique. It is recommended that not more than 3 attempts are made before moving on. The tool simultaneously primes the team to consider front of neck rescue as the situation evolves toward the can't intubate, can't oxygenate state at the bottom of the vortex. Successful front of neck access will also lead to safe oxygenation.
Repeated attempts at airway instrumentation is to be avoided. Limit the number of attempts at each non-surgical technique to avoid edema and the creation of a cannot intubate, cannot ventilate situation. A maximum of 3 attempts at each is recommended. If the best effort has already been attempted, it is appropriate to move straight on to another lifeline. This graphic represents a systematic approach to achieving the best attempt at each of the 3 lifelines. It includes manipulation, use of adjuncts, changing the size and type of equipment, ensuring good oxygen flow and suction if appropriate, and using a muscle relaxant to reduce muscle tone. The systematic approach can be used for each of the 3 lifelines for alveolar oxygenation.
A best effort at mask ventilation should involve increasing the oxygen flow, ensuring optimal positioning of the patient, that is, opening the mouth, jaw thrust, and chin lift. If the patient has dentures, you leave them in, removing cricoid pressure, and using a 2-handed technique to create a good seal between the face and the mask. The airway should be suctioned to clear secretions and debris, and an oropharyngeal airway or nasopharyngeal airway should be placed to optimise airway patency. Consider deepening anaesthesia or adding muscle relaxation, particularly if you think laryngospasm might be the problem.
Difficulties with laryngeal mask insertion can occur due to the inability to insert the airway into the mouth, difficulty negotiating the pathway through the pharynx, and misalignment of the laryngeal orifice. A best effort at laryngeal mask insertion should involve jaw thrust, optimising the head and neck position, and ensuring that debris and secretions are cleared by suction. Sometimes a different technique, such as twisting to get around the tongue, using a laryngoscope, or adding and removing air from the cuff can help. Sizing up or down, or trying a different type of laryngeal mask altogether can be useful. As with mask ventilation, deepening anaesthesia or adding muscle relaxation may help to overcome laryngospasm.
The process of endotracheal intubation can be divided into 3 components. 1. Getting a view of the larynx. 2. Delivering the endotracheal tube to the laryngeal inlet. And 3. Feeding the endotracheal tube from the laryngeal inlet into the trachea. Intubation may become challenging due to the inability to complete one or more of these steps, and optimisation interventions should be targeted accordingly. A best effort at intubation involves optimising the patient position, removal of dentures, suctioning debris, external laryngeal manipulation or burp, and removing cricoid pressure. If the epiglottis is floppy, lifting it up may enable better visualisation of the larynx. A different size or type of blade, or a different laryngoscope, such as a video laryngoscope, may also enable a better view. Passing the tube through the cords can be helped by using a rigid stellette or bougie, or trying a smaller sized tube. As before, ensure that the patient is adequately anaesthetised and paralysed.
The team are now demonstrating the use of the Vortex model to help make decisions during a difficult intubation. Endotracheal intubation has been planned as the primary airway technique for this patient. A first attempt is made using a curved Macintosh blade, and there is no view of the larynx or epiglottis. Suction is used to clear the airway. Paralysis is confirmed, and external laryngeal manipulation is attempted. A call for help has been placed, and the anaesthetist is now trying to achieve alveolar oxygenation using face mask ventilation, using his best attempt at ventilation. A second attempt at intubation is made. The patient is well positioned and the larynx has been manipulated, and a video laryngoscope is used. A good view is achieved, but the endotracheal tube is not able to be passed into the trachea. A third and best attempt at intubation is made by the second anaesthetist using a hyperangulated blade. To do this, an endotracheal tube will require a stellette shaped in a hyperangulated shape. The tube is not able to be passed into the larynx, although there is a good view. Successful oxygenation is eventually achieved using a laryngeal mask airway. The patient is now safely oxygenated or in the green zone.
The green zone is entered when one of either endotracheal tube, laryngeal mask airway or face mask is successful. This zone is confirmed by the improvement in oxygen saturation and the detection of end-tidal carbon dioxide. Although the rescue technique may not have achieved the original airway outcome of protection of the airway from aspiration, the patient is safe. Entry into this zone allows for the team to make decisions about the safety of proceeding with the surgery or the need to abandon anaesthesia and surgery, awaken the patient and defer until awake intubation can be offered.
Should all non-surgical airway attempts not achieve safe oxygenation, a can't intubate and can't oxygenate situation needs to be declared and front of neck access performed in order to achieve oxygenation. This technique will be covered in another video.
After difficult airway management, it is important to accurately record the events and document details about each technique used. The patient will need to be informed and advised about what technique was ultimately successful. It is useful to make copies of a letter with details and recommendations for future airway management. Communication with the patient, their own doctor, and with others in the hospital is required.
It doesn't matter where you start on the Vortex. Aim for the best attempt at each technique to achieve alveolar ventilation. Limit the number of attempts at each technique. If your planned airway technique does not achieve alveolar ventilation, use the Vortex approach to prompt the team to move on to another technique for oxygenation, all the while preparing to proceed to surgical rescue when indicated. Once you're in the green or the safe zone, consider your next steps. This zone will allow time to mobilise other resources, including expert help, to make decisions about proceeding with surgery using the alternate airway, conversion to an endotracheal tube, or a secure infraglottic or transtracheal airway. Thank you for watching this training video on the Vortex approach to safe airway management. We would also encourage you to check out the other videos in this series.